We're ready.
Great. Hi, and welcome everybody to this virtual High Five to HIPEC Finding Hope in Health with Peritoneal Cancer. My name is Stacey Cohen. I'm one of the medical oncologists here at Fred Hutch. And also shown on the slide are Doctors Mogal and Sharib, who are my co-organizers of this event. And we just really want to welcome you to this great event, also a sponsorship by ACPMP and PMP Pals, who we'll be hearing about later. So this is just really meant to be an opportunity for us as medical providers to do outreach to anybody and everybody who has an interest in this area. We're going to highlight definitely GI cancers, but also be talking about some different areas where peritoneal cancer is one that we are trying to really apply our expertise and hopefully answer some questions and also maybe raise some new opportunities for people who are unfamiliar with HIPEC and want to learn more about it. So with that, I am super excited to start our agenda. This is going to be all virtual today. And so, if you have questions, please use the chat box. What we'll try to do is when somebody is speaking, they won't really be able to answer questions, but then after they're done speaking, they will look at the chat box to try to answer some of those questions. And those of us that aren't speaking will try and answer questions as the day goes along. So feel free, if something pops into your head, feel free to put that in the chat box. So I'd like to start with the land acknowledgement statement. The Fred Hutchinson Cancer Center acknowledges the Coast Salish peoples of this land, the land which touches the shared waters of all tribes and bands within the Duwamish, Puyallup, Suquamish, Tulalip, and Muckleshoot nations. So as I said, I'm Stacey Cohen. I am an associate professor here at Fred Hutch and at the University of Washington, Division of Hematology Oncology. I'm joined today from the doctor side by Doctors Mogal and Sharib, who will each be speaking today. And then we have many other critical and crucial staff members from Fred Hutch that really are part of the multidisciplinary team that makes up HIPEC Clinic. And so we'll be talking with us as well. So this is me. I'm giving the welcome and introductions, and next we'll be joined by my colleague, Dr. Mogal. And Dr. Mogal and I have been working together since he joined the Fred Hutch now a couple years ago. He's a board certified surgical oncologist. He is the co-director of the HIPEC Clinic. And he really lends tremendous expertise into thinking about treatment of peritoneal cancers, neuroendocrine tumors, and sarcoma. And he is really the person that I would say has kickstarted our strength and abilities in the HIPEC area. So with that, I'm going to turn it over to him, and he's going to talk a little bit about types of appendix cancers, because this is critically important to how we think about HIPEC and different opportunities for peritoneal malignancies.
Thank you, Dr. Cohen. And I assume folks are able to see my screen.
Yes.
That looks
Thank
great.
you. All right. So with that, I'm just going to talk a little bit about the types of appendix cancer and how it relates to outcomes, because that's, there are lots of different misconceptions about what appendix cancer is and how these cancers spread and how they're treated. It's one of the first few things that you will hear from your clinicians when you encounter, if you happen to encounter them for treatment of your cancer, or for if you're accompanying your loved one for treatment of their cancer. So just as a background, appendiceal neoplasms or cancers are rare tumors, very, very rare compared to common cancers like colon or breast cancer. Often diagnosed either with appendicitis or, unfortunately, when patients present very late with advanced peritoneal disease. And the prognosis often varies based on the pathological subtype. This is critical to understand. Peritoneal disease is advanced cancer, and it's unfortunately fatal if not treated. And treatment often requires, in addition to other treatments, cytoreductive surgery and HIPEC. Symptoms are often non-specific, usually some indigestion, sometimes bloating, because of fluid buildup or change in bowel habits, nausea, decreased appetite. Some people can have weight gain because of the fluid buildup. Oftentimes people have weight loss because of the cancer spreading. And uniquely in some women, it can cause infertility, although that's not a common way it presents. And sometimes it's diagnosed incidentally when people are having surgery for other various reasons. So this comes to the classification. It's important to remember that there are different subtypes of appendix cancer. Even though appendix cancer is rare, it's an umbrella term. There are different subtypes which really determine our treatments. So commonly and most easy to understand is they're classified as these non-infiltrative tumors and what we call infiltrated tumors or adenocarcinomas. The non-infiltrative tumors are usually the low-grade appendiceal mucinous neoplasms or the high-grade appendiceal mucinous neoplasms, whereas the infiltrative tumors can be either mucinous adenocarcinomas or they can be non-mucinous or intestinal type adenocarcinomas. And then there are subtypes called signet ring cell cancer as well as goblet cell adenocarcinomas. And the reason I classify these as all one type is because the treatment by and large is based on whether it's a non-infiltrative or if it's an infiltrative, even though there are subtle differences between them. So these mucinous neoplasms tend to be these large fluid-filled appendix that is filled with mucin. This is just a representative picture of a CT scan as well as what we see in the operating room for these large mucinous appendiceal tumors. And this is a representative of a specimen of the mucinous neoplasm in this patient where the appendix had not ruptured. And management is typically done with appendectomy with a negative margin. We usually do not do extended resections, right colon resections for these, except when they're high grade. And then it's important to know if you are one of the lucky few that get diagnosed with appendix cancer before pseudomyxoma, whether there's mucin outside the appendix, and if this mucin has any cells or it's purely acellular, because prognosis is based on that. We tend to follow some patients, especially those who are high risk, over a long period of time, but the newer guidelines state we don't need to follow patients that have intact appendiceal mucinous tumors without any spread. Now, the adenocarcinomas, on the other hand, are more invasive and more aggressive tumors. In patients, we typically do right colon operations. And then it's these patients that we typically many a times follow up with chemotherapy. And Dr. Cohen will talk a little bit more about that later. And patients with adenocarcinomas tend to get surveillance and follow-up for longer term. So what is pseudomyxoma peritonei, which is a term often you will encounter, unfortunately, when you get diagnosed with this condition? It's an entity characterized by accumulation of gelatinous fluid, also called mucin, buildup into the abdomen with or without the presence of tumor cells. And usually it's caused by mucinous neoplasms or mucinous adenocarcinomas. Unfortunately, it is considered advanced and stage 4 disease. This is the stage most patients unfortunately present to us at. And when we look at the classification, without getting into the history of these tumors, they are classified either as low-grade mucinous carcinoma peritonei, formerly called DPAM, or mucinous carcinoma peritonei high-grade, also called PMCA, and lastly, the signet ring cell mucinous carcinoma peritonei. And the surgical treatment is primarily cytoreductive surgery and HIPEC. Dr. Sharib will cover a little bit of that in his talk shortly. But in general, these operations can be very challenging and morbid. And so we have a full multidisciplinary team that evaluates you, including a tumor board discussion. And you will hear from some of our multi-D team members today about their specific role in getting patients through surgery. And then we have certain standard criteria we use to ascertain patients' eligibility for surgery. For example, their medical conditions, whether they're on chemotherapy, and whether they need a laparoscopy to ascertain disease burden. But what determines outcome is among several factors, primarily these 4 different factors. One is the pathologic subtype, which we saw earlier. And the thing to take away from this slide is that the higher you are on the line, the better your prognosis. And as you can see, patients who have a lot of mucin without any tumor cells tend to do the best. And then intermediate are the patients with mucinous carcinoma peritonei high grade. The signet ring cell cancers, unfortunately, tend to have the worst prognosis. And this does not mean that patients cannot be treated. It's just an important thing to establish right at the outset, because it can kind of help set expectations for you and your treatment team. This is another slide showing the same thing. It just uses a different classification system. And then the other thing that determines outcomes is the quantity of tumor in the abdomen, also called the PCI score, and what we leave behind after resection, which is called the CC score. So the PCI score is determined by dividing the abdomen in several regions and calculating a score in each of those. The lowest score is a 0, which means there's no tumor, and the highest score is a 39. And as you can expect, the higher the score, the worse the prognosis. The CC score looks at what we leave behind after we are able to successfully remove all the tumor, and that determines prognosis, arguably even more than the PCI score. Ideally, we want a CC score of 0 or a CC score of 1, because that means almost all the tumor has completely been removed. And why pathology correlates with the PCI and CC score, this slide underscores that. So in low-grade patients, even though the ideal is a complete resection or a CC0, sometimes we can provide some benefit with even incomplete surgeries as long as it's not just purely palliative. Whereas in high-grade patients, it's very imperative that we complete the operation and take out all the tumor and leave no tumor behind, because otherwise the prognosis varies dramatically. There are some aspects of what we see intraoperatively that unfortunately determine patients not to be candidates for complete surgery. And this is when the PCI is so high that it causes critical organ involvement, like the bile ducts or the ureters, which are the tubes that run from the kidney to the bladder, or if there are multiple liver lesions, or worse still, if the patient has multiple areas of bowel obstruction. And then lastly, what determines outcomes is tumor genetics. I won't spend too much time belaboring this, except to say that even within certain pathological subtypes, patients can have different prognosis. So for example, two patients with low-grade disease may not necessarily, unfortunately, behave the same. This slide, for example, shows that even within low-grade, there are different genetic clusters that can be seen. Some patients do worse, some patients do better. Some of the commonly encountered mutations you can see up are here. Not all of them have targeted therapies available. That's a discussion to be had with your oncology team. And then lastly, now we have started to look at more different patterns of these mutations among different people. So for example, we use a combination of these patterns to see which patients are high risk for recurrence and which patients have poor survival. And with that, I will hand over the presentation to my colleague, Dr. Sharib. Dr. Sharib is an assistant professor of surgery and surgical oncology at UW Medicine and Fred Hutch Cancer Center. He joined our team approximately 2 years ago and has been an integral part of our multidisciplinary HIPEC clinic as well as program. He also does research and is currently looking at some of the ways that tumor cells behave in the body and what types of treatments might best be utilized against those kinds of tumors.
Thank you, Dr. Mogal. Are you seeing my PowerPoint correctly? All right, excellent. Well, thank you, everyone. I'm really excited to be here. Actually, this is my third High Five for HIPEC event, so really happy to be here with our group, and hope that everyone is able to learn a lot today. I'll be presenting on some of the background of what is the cytoreduction and HIPEC procedure, the background of HIPEC in general, and then some emerging technologies as well. Brief overview of the goals that I hope to accomplish today. I just will reiterate some of the scope of the problem and give a background on kind of how peritoneal metastases are a part of the diseases that we take care of and that we're focusing on today. Of course, go over the cytoreduction and HIPEC procedure with maybe a little bit more depth, and then again discuss some of our newer technologies that are coming down the pipeline from a technical standpoint. Obviously, you'll hear more about systemic therapy and chemotherapy in the next talks as well. So our theme of the day for this year is the management of advanced appendiceal and colorectal cancers. And one of the things to note is that this is a growing problem. So this table here on the left is from the SEER database, which is a big National Cancer Institute sponsored database that should be a relatively representative snapshot of incidences of cancer. And this is from 2010 to 2019. It shows that appendiceal cancers were actually the fastest growing cancer by incidence of all GI cancers. Colorectal is also increasing, not quite as fast, but still an increasing problem over that time. And this is particularly true for the so-called early onset cancers, which affect people less than 50 years old, as we see kind of in this table here to the right. However, we can also appreciate that the incidence has increased across all ages as well. Why is this important for the conversation we're having today? We all, as part of the HIPEC program, treat advanced colon and appendiceal as well as other cancers. And to kind of understand how big of an issue that may be for the two cancers that we're mainly focusing on. But for colon cancer, if the disease is to spread beyond the colon, there is about an equal distribution of spread, maybe a little bit more heavily towards the liver, between the lungs, liver, and the abdominal cavity. And we typically think of those as three distinct sites, and some of the treatments that we're describing will generally be for people who are fitting into one of those categories rather than having overlap, except for in very distinct populations. But while colon cancer is relatively evenly distributed, appendiceal cancer, for people who have spread outside of the appendix, nearly all of them will have spread to disease in the abdominal cavity. And so the ability to treat peritoneal disease, particularly in appendiceal cancer, is very, very important. And for colon cancer as well, it is a large burden of disease. And so while the exact mechanism of peritoneal dissemination or peritoneal spread is not completely understood in either of these diseases, particularly because it actually can arise even without perforation of the primary tumor in the setting of invasive disease, which is unlike the way we think about it, as Dr. Mogal had mentioned, for more of the low-grade or non-infiltrative diseases such as Lamin. But because of that ability in appendiceal and colorectal cancers, there's still some questions about how exactly peritoneal spread happens. But we do see that in general, there seems to be some pattern that's known as the redistributive principle, where there's emanation from the right lower quadrant, where these organs tend to begin in a counterclockwise pattern, with a propensity for accumulation in the pelvis, which is right next door, the omentum, which is a kind of apron of tissue that lies over most of the intestines, as well as the right upper quadrant above the liver. So for any of these cancers, once appendiceal or colorectal cancer or low-grade disease is established, we use several tools to stage and further evaluate the cancer. These will include axial imaging modalities such as CT or MRI, blood-based biomarkers. You may have heard CEA, CA19-9, CA125, or endoscopic evaluations such as colonoscopy, which nearly all of our patients will receive. And while we can pretty accurately diagnose disease in other organs such as the liver or the lungs with these imaging studies, even our best imaging can only see or accurately identify peritoneal disease in about 2/3 to 3/4 of the time. So the incidence and the extent of disease in the abdominal cavity can be missed or underestimated. And for this reason, our kind of treatment paradigm is when there's a suspicion of peritoneal disease, either by kind of secondary signs on CT imaging or for other reasons. Our primary diagnostic evaluation almost always includes what's called a diagnostic laparoscopy, where, as we see on the right-hand side, a camera is inserted into the abdomen. We gain a direct videoscopic view of the peritoneal cavity, of the abdominal cavity. We're able to visualize areas of disease, take biopsies, and we can create that topographic map to be able to assign a score called the PCI, which Dr. Mogal had shown previously, and communicate with the patients and each other kind of the overall extent of disease. Once peritoneal disease is established, nearly all patients with cancers will receive systemic therapy prior to consideration of any sort of surgical treatment, and you'll hear more about that in Dr. Cohen's talks in the future as well. I won't go over this in too much detail, but after all, repetition is the key to adult learning. So we do again use a scoring system called the PCI to essentially communicate and also understand the potential disease resectability for patients with abdominal tumor. Just taking a pause, but moving now to the procedure itself. First of all, it's important to note the goals of the operation. And so, as you heard from Dr. Mogal, to really have meaningful benefit for people with invasive disease, and as it's always the goal, even for people with the non-infiltrative side of the diseases, the goal of the procedure is to remove all visible sites of disease to get that CC0 or CC1 resection. Of course, when considering patients for surgery, you also heard that they should have either disease stability or response to chemotherapy, and they should be fit to undergo a big operation. And the operation itself, it is generally an open surgery where a large midline incision is made. There are select cases where this can perhaps be less invasive or even done with minimally invasive techniques. However, these are the rarity and are very much on a patient-by-patient basis. Once the abdomen is explored, there's a self-retaining retractor, which gives us exposure to be able to, again, look at all areas of the abdominal cavity under the diaphragm, the liver, the stomach, the omentum, and the intestines to be able to redetermine the PCI score and make an intraoperative decision about whether the disease is fully removable on that day. The cytoreduction procedure that ensues is tailored to each individual patient, given, again, the pattern of disease present, but broadly, it doesn't involve removal of all sites of visible peritoneal disease or abdominal wall lining disease through stripping of that what's called the parietal peritoneum, the lining that's not over specifically over other organs in all quadrants of the abdomen where disease is present. We standardly do what's called an omentectomy, where that apron of fatty tissue that covers the intestines is removed. And then, of course, there's the resection of the primary tumor if that is still present. This can be a long procedure. We usually schedule it for a full day in the operating room. It can take 8 to 12 hours, and it can include many organs resected, multiple bowel resections, and anastomoses, or possibly even ostomy creation. Again, the goal of the operation is to achieve what we call optimal cytoreduction with a CC0 or 1, meaning that there is no tumors larger than about 2.5 millimeters remaining in the abdomen. Once the cytoreduction portion of the operation is completed, HIPEC is performed. And again, HIPEC, from a technical standpoint, is essentially insertion of 2 cannulas into the abdominal cavity, one that brings chemotherapy in, and the other that helps to drain the abdomen and goes through this heating pump and system and circulates that chemotherapy in a heated fashion through the abdominal cavity for approximately 60 to 90 minutes. The most common drug that we use is called mitomycin. And again, it's being perfused for a period of time at about 1 liter a minute rate. The reason why we do the HIPEC in the first place is for various aspects of the rationale. So firstly, with this closed system, we can infuse a relatively high concentration of the medication into the abdominal cavity to treat the microscopic disease or individual cells that may be left remaining after the surgical procedure, while really having a low absorption rate so that there's not systemic toxicity, so people don't get as sick from that high dose as they would if it was going through their bloodstream. There actually is a direct cytotoxic effect of the heat itself. And then the heat actually can potentiate the cytotoxic, the cell-killing effect of several of the chemotherapy agents we use. And typically we choose medications that both are not very absorptive, but also can penetrate the tissue well and might be potentiated by the heat itself. Just a word on some emerging technologies. Again, while HIPEC uses chemotherapy in a liquid solution and is certainly the most widely used method for intraperitoneal chemotherapy delivery, pressurized intraperitoneal chemotherapy, or PIPAC, is a different approach that takes advantage of laparoscopy to actually introduce chemotherapy in an aerosolized or semi-gaseous form. And part of the hope of that is to maybe better distribute the drug throughout the abdominal cavity, use the pressure itself to push it into the tissues in much the same way that the heat is used in HIPEC. From a technical standpoint, this is a minimally invasive procedure. The abdomen's accessed in a similar manner to as we do for a diagnostic laparoscopy with laparoscopic ports, at least one for a camera, usually another for perhaps a biopsy. And then this capno pen, which is the aerosolizer, is placed into another port that brings in pressurized an aerosolized chemotherapeutic agent from a pump that's outside of the body. At the current moment, this is mainly in use for patients who are not candidates for HIPEC therapy. It has been around for a few years in Europe and has been in the United States for just a couple of years now. At the current stages, we're studying it rigorously to learn about the safety profile and eventually the efficacy of the modality. And on that note, I think if you joined this program previously, we did mention that we are part of the consortium. We have not opened this this method at our center yet, but we're working on being an active participant in the future. The closest place where this is being done is City of Hope, and we have certainly referred patients down there. But we're just getting data from their early studies that it was considered safe by our kind of standardized clinical trial method, and they're showing actually some reasonable data about patient-reported outcomes as well. So in conclusion, appendiceal and colon cancers are increasing in incidence, particularly in patients younger than 50 years. Cytoreduction and HIPEC is an aggressive local, regional, or surgical therapy for peritoneal spread from these diseases. It's generally paired with systemic therapy for all of our invasive diagnoses. And that multidisciplinary team that we're showcasing today is really important for all of the care of patients with advanced colon and appendiceal cancers. And new technologies such as PIPAC may be an alternative for later stage disease, though certainly more data is needed. So I want to thank you, and please feel free to email me if there's any questions. Hope everyone has a really informative day today.
Okay, thank you to both of my colleagues for that informative conversation about this from the surgical perspective. I'm now going to bring it back to the medical oncology side of things. And for my collaborators, yes, the one about is it more effective when you have a recurrence? If someone else can answer that, because I was in the middle of typing, but now I need to talk. So thank you. Okay, so please keep the chat messages coming. What we try to do is if you put in the chat, it comes to the host, so we'll repost your question and then answer it. So sometimes when there's multiple people, the thread can get a little messy, but do read that because there can be some interesting tidbits that come up along the way and gives you an opportunity to ask some of the questions that you think of as you do. So now I'd like to bring this again to the medical oncology side. So we're going to think about systemic therapy in patients with peritoneal cancers. So just thinking about what even is systemic therapy. So let's compare local therapies and systemic therapy. So local therapy is this idea of delivering a treatment to one body part, like just the liver or just a region of the body like the peritoneal cavity, and you're only treating that area. Whereas a systemic therapy is often given intravenously, sometimes pills, with the intention of going everywhere, and it's transmitted through the bloodstream. So whereas local therapy is more targeted, systemic therapy is obviously system-wide, and we use those for different ways. So local therapies you're going to use when there's really limited spread, you want to do curative intent, or maybe you're doing what we call palliation. You're trying to just address symptoms, like there's one bony metastasis that's really painful, so we want to treat that one area, recognizing it doesn't change overall survival, but it can really change quality of life. On the other hand, systemic therapy can be used in a number of ways. We can use it to shrink cancer burden, like preoperative treatment. We can use it to control the growth of cancer, like in metastatic disease, or reduce the risk of recurrence in the post-operative setting. And I underline two of these because that's really how we think about it, and specifically around perioperative therapy for HIPEC is shrinking it before and maybe reducing the risk of recurrence after. Side effects, local therapies are going to be more regional to wherever you treat, whereas more global and systemic therapy. And local therapy is great, but it really misses any cancer outside the targeted area, whereas systemic therapy, the idea is that you can treat what you can see on scans as well as micrometastatic disease. So for those of you who don't think about chemotherapy as much as me or haven't encountered as much, I just want to go over some of the names that you might see. So 5-FU and capecitabine are our backbone. We can add oxaliplatin, and then we call that combination of those two drugs together FOLFOX. Or you can add 5-FU and irinotecan, we call that FOLFIRI. You can do all three of them, and then we either call it FOLFOXIRI or FOLFIRINOX. The names are, it's really the same drug regimen, just with slightly different dosing and different terminology, but FOLFIRINOX is the one that we tend to use. Sometimes people get IROX if they can't have 5-FU. And then we can add a drug bevacizumab with the trade name is Avastin, as many people refer to it, and that's a helper drug. Or we can add the EGFR inhibitors, panitumumab or cetuximab, but we don't put them together because we know that's harmful. And then we have several other drugs approved in GI cancer, especially colorectal cancer, so regorafenib, trifluridine tipiracil with bevacizumab, and fruquintinib. And these are all FDA approved as kind of a second tier after you have had progression or intolerance to the first 5. And what we've seen over time, so this is just all colorectal cancer, regardless of metastasis site, when you treat patients with sort of sequential chemotherapy regimens, so one regimen after another, is our typical treatment if there's no surgery involved. And what we've seen is, this graph is just showing that over the last several decades, we've seen that people are living longer with metastatic disease. And we think that's partly because as we develop new drugs, and find new drugs that are actually effective and figure out which patients to give them to, then we're able to improve survival over time. So it's been greatly improving our survival, but of course is not curing patients like we want. And this is a tricky problem. Again, looking at these graphs, we think about everyone is starting up at 100%, so everyone is alive and doing well at the time of the graph starts, and then the numbers drop off. In this case, it's overall survival. So if someone passes away from any cause, the number ticks down. And what this is supposed to show is that patients who have cancer in the peritoneum, which is the purple line in the middle here, that those patients don't do as well as patients with other sites of metastases. And the worst is the red line, peritoneal and other sites like peritoneal and liver. And this is really important because, of course, we want to give everyone the best outcome possible. But just statistically speaking, we have to realize that it's a lot harder to get the outcomes that we want, even when we try as hard as we do, especially with patients who have peritoneal disease with other sites of disease. So how do we use chemo for peritoneal disease? We could just say, look, this is metastatic disease. We're going to try and control it to the best way possible. And we give chemotherapy sort of indefinitely using different regimens, one after another, as long as they're working so that we can control the cancer. But if someone wants to try to have surgery, then our goal is to give as aggressive a therapy as possible prior to surgery, really to try to shrink down and control that cancer. So we want to shrink the cancer, we'll call it decreasing the tumor burden. We want to get rid of ones that we can see and also ones that we can't see, because we know very well that if we do a CT scan or even a PET scan or MRI or any of them, none of them really fully appreciate how much disease there is in the peritoneum. And so the goal is to really try to maximize that control, recognizing that at minimum, there's the amount of cancer that we see on the scans, and there could be much more than that. And again, we also want to think about microscopic amounts of metastatic disease, too small even that if Dr. Mogal or Dr. Sharib went in to do the diagnostic laparoscopy, too small for even them to see on the cellular level, but those cancer cells can still cause problems later, so the goal is to kill that off with the chemotherapy as well. So how do we do this? So again, our standard approach, if you have someone with, let's say, metastatic colorectal cancer or appendix cancer, is to just give chemotherapy regimen after another. When they stop working, we have those second-tier drugs. We have clinical trials that we're trying to use. But in this sort of aggressive management, we would give the maximum possible chemotherapy. We call it neoadjuvant, which means before surgery. So we are giving it with the intent of kind of trying to control the cancer before surgery for 4 to 6 months. And then we follow that with the cytoreductive surgery and HIPEC. And along the way, we're going to be doing CT scans, usually every 2 to 3 months, to basically ensure it's not worsening. We'd love if we saw improvement, but again, we know that the CT scan could underestimate disease. So our hope is that at least it's not getting any worse. And then around 5 months in, or when we feel like somebody's probably not going to tolerate chemotherapy for that full 6 months, then I'm asking my surgical colleagues to do a diagnostic laparoscopy and actually look with the camera and give us an idea, do we think surgery is possible or not? If everything looks good, the chemotherapy tolerance was good, the CT scans look good, the diagnostic laparoscopy gave us the green light, then we'll actually pause chemotherapy and try to have about 4 to 6 weeks off and then go to cytoreductive surgery and HIPEC. But a really key point is that we need the team talking together throughout this process. So we call that a multidisciplinary review, sometimes sort of referred to as a tumor board. But the idea is that no one person can be making these decisions by themselves. So I can give chemotherapy, but I need to know, are we ramping up to surgery, or is that something that doesn't feel like it's likely? And my surgical colleagues need to know, what's the plan for chemo? How long do we think someone should be on? What's their tolerance like? Should we go up or down in the intensity to make it more tolerable? And so we're always trying to balance quality of life and efficacy and toxicities or side effects and just what their goals are. So I want to show you a little bit of data that just kind of helps explain why we think about doing chemotherapy. So, because everyone comes and says, can't you just take it out? And yes, absolutely. If that was the best way possible, that would be our recommendation. But this was a trial called the Carroll 6 trial, where they actually randomized patients to going either straight to surgery, which is the column on the right, or they had the surgery, but they had some chemo before and chemo afterwards. So when we look at the people that had chemotherapy before, they had a variety of different chemotherapy regimens. And the number on the right, overall response rate, about 28% or about a third of patients, that's actually describing the amount of patients that they saw like very good shrinkage. So not everyone did. Some people just had stable disease, which again is okay. But about a quarter to a third of patients actually had the cancer look clearly smaller after getting chemo. Then 89% of them were successfully able to go through the surgery, and they had planned that patients would get chemotherapy after. But if you have, been through this process or know someone that has, you'll know that it can be a really tricky surgery to recover from. And so only a third of patients actually went on chemo and completed all the chemo that was planned after. So it was hard because a lot of patients did not feel well enough to get chemotherapy or just didn't tolerate it as well. On the other hand, again, half the group went straight to surgery, but actually only 86%, so not even the same amount, had a good complete CRS HIPEC, suggesting that we really could do chemotherapy somewhat successfully, that the complications were similar, and giving chemotherapy for it definitely did not hinder or hold back our ability to do the surgery, which is super important because if we think that that is the procedure that absolutely needs to get done, I don't want any chemotherapy to get in the way of that. But maybe what it did do is treat some of those patients early with chemotherapy who were never going to get surgery, and maybe it did shrink it and have a better surgery. So as Dr. Mogal mentioned briefly, every once in a while we find the needle in a haystack, and we don't just have to give standard chemotherapy, we actually can give a targeted treatment. And so each one of these is less than 5% of metastatic colorectal cancer, maybe even less in appendix cancer. And so these are ones that we look for on all patients. This is called molecular testing or next generation sequencing or panel testing or gene testing of the tumor. And it's the idea that we want to figure out what makes your cancer tick. And if we have a drug that puts the brakes on that, then that may be the best, most effective therapy. So if a BRAF V600E mutation is found, we have the combination of NCRAF and cetuximab, recent FDA accelerated approval for the combination with FOLFOX, if you find that right away as your first therapy. If someone has HER2 overexpression, not mutation, but overexpression, then we would do trastuzumab and tucatinib, or the antibody drug conjugate trastuzumab deruxtecan. If there is microsatellite instability or a high tumor mutation burden, then we would use immunotherapy like a PD-1 inhibitor. If there's a G12C, we'd use adagrasib cetuximab or sotorasib cetuximab or panitumumab rather. And then rarely, less than 1%, there's NTRK or ALK mutations. There's targeted therapies for those too. Now, if you are good at looking at Google or you got a communication from a friend, you might have heard about this drug dostarlimab, which is a PD-1 inhibitor reported to have a 100% complete response rate. I bring it up because I want you to know that, yes, we know that immunotherapy can cause amazing responses in some patients. This specific trial was in localized rectal cancer, so it hadn't spread to metastatic disease, just the one primary tumor, maybe lymph nodes. And they did see really good results, but I'll note that it wasn't replicated at other centers and is certainly not as impressive for patients with metastatic disease. So thankfully, immunotherapy can be really effective in the rare cases that we get to use it, but I just bring that up because it's a commonly asked question. After curative intent treatment, we're going to be looking for symptoms. We're going to be looking for abdominal or digestive symptoms like bloating, pain, constipation, or diarrhea. We're going to be looking at blood tests that have already been referenced, CEA, C99, and CA125 tumor markers. Check with endoscopy, colonoscopy, and doing scans. Usually CT scan, rarely PET or MRI. But even then, recurrences can be really hard to detect. There's a lot of scar tissue there. There's a lot of new changes in the body, and it can be very subtle. So I just want to go over quickly the concept of circulating tumor DNA, because I think that comes up a lot as well. So going back to biology, we have DNA into RNA into proteins. We have single cells that can grow up and form a tumor. So when you want to actually take a cancer sample, you could do a tissue biopsy, put a needle into a tumor and suck out a bunch of cancer cells and look at them under the microscope. Or we could take a blood sample and look for a protein like CEA, or a DNA sample, which is what's called a liquid biopsy, and that's the circulating tumor DNA. So we all, as our cells break down, the cells release cell-free DNA or cfDNA. And so whether you have cancer or not, everybody has this in their blood, but they can use it as a screening tool, first used in pregnant women to screen for chromosomal abnormalities. But now we also use it to look for tumor DNA. So ctDNA or circulating tumor DNA is this idea of looking at these dynamic shed of cancer cells into the blood and look for mutations that are highly specific for cancer. So we'll talk about MRD, which is molecular residual disease or minimal residual disease, or the idea that maybe the scans look good, the labs otherwise look good, but then the ctDNA could pick up these rare fragments of DNA, and it has a very short half-life. So that means that if it's positive, there is definitely cancer somewhere in the body, though we don't know where. And so what do we do with this? The idea is that if we have all patients here in the middle in the black line, if patients are negative, maybe they don't need as much therapy. So we could de-escalate treatment because we know that those patients are actually going to do well. That's what this blue line is going to show, that some people actually do better than all patients combined. Where if it's positive, then maybe we need to give more intense therapy because generally speaking, these patients are going to do worse. So the hope is that you could use ctDNA not as a be-all end-all, but to kind of guide practice. And so as we look at these graphs again, we see separation of the curves. People who are positive tend to do way worse than people who are negative. People who are negative and stay negative do the best. Converting from positive to negative, we can kind of follow that over time. But these studies are coming from analyses of 1,000, 2,000 patients, largely in colorectal cancer. And I show this data, not appendix cancer, because appendix cancer being mucinous, like Dr. Mogal was going over, it's really hard to pick up on ctDNA because it doesn't have as much cancer content. It doesn't shed as much. So I will admit I don't send as much ctDNA for appendix cancer, though maybe part of it is which assay we're using. And so we need to figure that out more over time. But that may be something that comes up if you have an appendix cancer. We've tested this also. I just want to show in stage 4 patients, we know that many patients will recur after surgery. So we'll see a high frequency of ctDNA. We see that it gets suppressed during adjuvant therapy. And that's what these percentage numbers are supposed to show here in the middle. And then finally, in surveillance in that long-term follow-up, we will see a high frequency of ctDNA positivity of recurrences. So even with our best treatments, you're able to go through chemo and CRS HIPEC and everything. We know that unfortunately recurrence rates are high. And so one of my jobs is to try to figure out who is going to recur and when. So hopefully we can treat more intensely. So what do we do in clinic? We think about what's the goal? What type of treatments does somebody already have? What other medical issues do they have that might impact our ability to give treatment? Have we done the molecular testing? Does that let us do one of those rare, targeted therapies? Maybe we could add drugs or remove drugs to make it better for surgery. And then that big question, does an attempt at surgery make sense? Okay, so that's it for me for now, the rest of this to come. And so thank you for listening to kind of like the didactic part of this morning or afternoon, excuse me. And so hopefully that gave like kind of a quick overview about appendix cancers, what HIPEC is, systemic therapy. We're going to take a brief break. Let's reconvene at 1:30 p.m. Pacific or whatever that means your time. And then we're going to jump into some of our more supportive and complementary care. So thank you, everybody, and we'll be watching the chat box.
Okay, I'm going to go ahead and kick us off if that's okay. Hope everybody had a
Tal,
quick break.
Sorry about that.
That's okay.
My video was not connecting. Thanks, Tal. So welcome back, everybody. We appreciate every one of you that have joined through the morning, and a lot of you that are still continuing to join even after the break. So with that, we'll go to our next speaker, Tal Ozery. Tal has been part of our multi-D HIPEC team ever since its inception. She is a dietitian by trade and is very integral to getting our patients through some very complicated surgeries. She grew up in Florida, and once she bought her ticket to Seattle to attend Baster University for her master's in nutrition and dietetics, she never looked back. She covers not only the HIPEC clinic, but also GI oncology clinics, both at Fred Hutch and Peninsula. And we're very glad she has joined us at the event today.
Well, thank you. That's very kind. Like you said, my name is Tal. I'm the dietitian or one of the dietitians on Dr. Mogal and Dr. Sharib's team. So today I'm just going to be talking about understanding the role of nutrition through HIPEC. There we go. And some of what I'll be talking today is going to be specific to sort of the Fred Hutch standard of practice that we do here. So preparing for HIPEC, everyone will be automatically scheduled with a registered dietitian, either myself or my colleagues, for your initial nutrition assessment. And during this assessment, we will, in general, be maximizing your nutrition status or trying to get you as strong as you can prior to surgery. And this, the recommendations might be different for everybody depending on where you're coming from. Like Dr. Cohen had mentioned, a lot of people are coming from, systemic treatment or chemotherapy prior to surgery. So what we are doing here is really trying to maintain your weight or perhaps even regain some weight or lean body mass. And we do this by addressing any barriers that you might have to getting adequate nutrition, adequate food or fluid. So sometimes dealing with some of those residual side effects from the systemic treatment. Also good to know that this is not the time for any major diet changes or shifts. Another thing that we talk about in that appointment is our immunonutrition pre-surgery. And this is because taking certain nutrients prior to our surgery has been shown to help your immune system going into and recovering from surgery. So what we're referring to here are some specific shakes that are high calorie, high protein, and they contain certain nutrients like arginine and omega-3 fatty acids for wound healing. And taking these shakes along with eating your normal meals has been shown to decrease surgery complications, infections, length of stay. So some pretty profound effects there. And the regimen, or the ideal regimen, is that you're having 3 shakes a day in addition to your normal meals and snacks starting about 5 days prior to surgery. I know that's not feasible for everybody, but that's sort of the ultimate goal. And then we're shifting to after HIPEC, CRS HIPEC surgery. So nutrition needs are very high to support healing. That's because this is a significant surgery and your body is in a state of stress that requires a lot of protein, a lot of calories to support. And eating during recovery, everyone's timeline is different. If you're unable to support your body with enough protein, enough calories, enough fluid by mouth, sometimes we are talking about the possibility of nutrition support. And that could look like a tube feeding, that could look like IV nutrition, IV fluid, just to make sure that we're supporting your body as best we can for healing. I would say in general, nutrition and eating starts to improve about a month after surgery, but it can take up to 6 months to get back to your baseline, sometimes even longer. So again, specific to what we do at Fred Hutch and University of Washington, after surgery, you'll meet with our inpatient dietitian, and she will talk to you about what your post-operative diet should look like and how to keep a food record. Because then once you are discharged, you'll be meeting with myself or my colleague once a week for generally 3 to 4 weeks after your surgery. And what we're doing during those sessions is really troubleshooting any side effects that you have from surgery, trying to get you to meet those needs. I would say the biggest ones are that you're generally not feeling very hungry, and when you do eat, you're eating very small amounts because of this feeling of fullness, which we call early satiety. And then towards those later sessions, maybe the 3rd or 4th week, we're talking about expanding your diet back to normal for most people. And we do this kind of in a systematic way, watching for any changes in your bowel habits or digestion. And, we can continue to talk about, how to meet those higher needs, smaller, more frequent meals, consuming calorie-dense fluids and foods. And then for survivorship, so looking a little bit more long-term, we really want to make sure you are getting adequate calories and protein, because this is so critical to regain strength and muscle mass after surgery. And I'm sure Jenica will talk, our physical therapist will talk a lot more about the physical activity piece, because that's a critical piece of the puzzle. And staying well hydrated is also very important. For some people, they will be on a modified diet more long-term. So for people that are at a small bowel obstruction risk, this will require a diet change to what's called a limited fiber diet. This can help to prevent any readmissions or hospitalizations. And I'll talk a little bit more about the limited fiber diet on the next slide. If somebody has what's called short gut syndrome, or essentially a large portion of your bowel is taken out during the surgery, that can compromise your ability to absorb certain nutrients. And so we do have to shift your diet again. It's important to stay very well hydrated. Again, eating smaller, more frequent meals, and we might even recommend specific nutrients to supplement because of that compromised absorption. If your surgery does include an ostomy, then there is a specific diet for that as well, and we could talk about that during our visit. So if you are unfortunately not a candidate for CRS HIPEC and you have bowel disease or some tumor that is obstructing your GI path, and what I mean by obstructing is essentially it's getting in the way of that movement of stool and food through your GI tract. At that point, you would be recommended to be on what's called a limited fiber diet. So fiber is the part of the plants that we eat that we don't absorb. And so it just travels along our GI tract. It eventually ends up in our stool. But if there's something in the way there, it can create a bit of a traffic jam or an obstruction. And so you would want to limit the total amount of fiber that you're getting in your diet, specifically the insoluble fiber or roughage. And in addition to that, you'll want to make sure that you're chewing all your food really thoroughly, getting that kind of physical breakdown really important in the mouth, and that you're drinking plenty of fluids to kind of move things through the GI tract. Another really important part of my job is myth busting, because I think a lot of people come to our sessions with lots of questions about nutrition and diet and how it relates to cancer. And a lot of the times that is misinformation. And so here are just kind of some of the common ones that we hear about, but there's really a lot. Sugar feeds cancer is probably one of the most common questions that we get. And for the purposes of today's discussion, we'll just say that there's really no need to overly restrict carbohydrates from your diet. Eliminating glucose from a healthy, well-balanced diet is really not appropriate or indicated in any way. However, it is always a good idea to limit our high carb, simple carbohydrate, non-nutritive foods. And what I mean by non-nutritive is that it's really not providing us any other protein, fiber, or anything else, vitamins, minerals. So these are things like soda, juice, and candy, cookies, etc. Fad diets, there's a lot, but alkaline diet, ketogenic diet, fasting, we hear about those a lot. And specifically for GI cancers, there's no studies that validate that these approaches are appropriate. And then as far as supplements go, current research doesn't support you taking supplements to prevent cancer. However, if, like we said before, if there was something resected during surgery that compromises your ability to absorb specific nutrients, we would recommend supplementing them. And that's part of our assessment together. Some resources here. So cookforyourlife.org is a really great one. This is developed by some of the clinical dietitians at Fred Hutch, as well as the research dietitians. And it's a nice index of recipes that abide by what are called the survivorship guidelines, meaning guidelines that are evidence-based to reduce chances of a recurrence. These are put out by the American Institute of Cancer Research, which is the next link. So another really informative website, as well as American Cancer Society. We've got some good articles on our Fred Hutch public-facing website. And then, of course, speaking to a registered dietitian can be very helpful. Specifically, what you're looking for is a certified specialist in oncology or a CSO dietitian. And that's all I have for you. And I will be sure to answer any questions that might have come up in the chat.
Thank you, Tal. With that, we'll introduce our next speaker, who is also an integral part of our multidisciplinary HIPEC evaluation team. I'm very pleased to introduce Jenica Holt. Jenica is originally from California and graduated with her physical therapy degree from George Washington University, moved to Seattle in 2021 from the East Coast, and has been at Fred Hutch for 4 years and with our program pretty much for the duration of that time. She's not only a certified physical therapist, but also a certified lymphedema therapist, and works alongside multiple different types of patients undergoing cancer treatment. Thank you for being here, Jenica.
Thank you for having us. Can you see my screen?
Yes.
Okay, great. Wonderful. My name is Jenica. I'm one of the therapists who works with Dr. Mogal and Dr. Sharib's team. My colleague and counterpart, Rachel Trussell, who you might see, is the other therapist that also works with the teams. So we're going to go over pre and post-op physical therapy needs. And this slide is just sort of a timeline of where you might see physical therapy. So the first point is you'd meet with FHCC physical therapy for prehab assessment and potential recommendations before surgery. The next would be the patient has surgery, they're admitted to the hospital for close monitoring, and at that time, there's also a physical therapy inpatient team that is separate from our outpatient team who you'd be seen by, and really the goal of PT in the hospital is to make sure you're prepped and ready to be just discharged to home. After that, if needed, you might come back to see us again in outpatient physical therapy for reassessment of ongoing needs, and also to just help you recover after surgery, rebuild strength, and provide any recommendations we can to get back to your activities of daily living. So what is prehab? So prehab can help patients prepare for the demands of surgery in advance with the goal of feeling stronger and healing faster afterwards. And there's a lot of research that shows the benefits of prehab before surgery. A lot of the research is in the orthopedic population, so total knees, total hips. But there is a lot of research out there actually for the CRS HIPEC population that prehab can be beneficial pre and then post, because it'll help you kind of recover from surgery as well. So again, the research shows that consulting and working with a PT prior to surgery can help improve functional outcomes and help you recover faster. So a typical prehab visit, this is sort of what it would look like. We check your overall movement and strength. We take preoperative measurements, which are basically like a baseline assessment. It gives us an idea of how you're functioning, how you're moving before surgery, in hopes that we can get you back there after surgery. At that time, we'd also recommend certain exercises and activities to do leading up to surgery, and then answer any specific questions and also provide some education on what the recovery might look like after surgery. So I just added these here because these are just general activity recommendations and exercise recommendations that we tend to provide for most patients. So our cardiovascular recommendations for most people is going to be about 150 minutes of moderate intensity exercise. And what that breaks down to is about 30 minutes per day, 5 days a week. And this is you're going out and doing, intentional walking or stationary bike, something of moderate intensity versus, just walking in the grocery store. We really are trying to have patients focus on coming up with a cardiovascular program. And then strengthening is another thing we recommend as well. In general, the research shows that people should be strength training about 3 to 4 times a week. And we can provide specific exercises at the pre-op eval to kind of recommend a home program. But ideally, you're working on sort of all the body groups, core, upper body, lower body as well. Other recommendations that we could include are also stretching, breathing exercises, which are really important post-op as well, and then balance exercises. And then post-operative PT. So these are just some generic kind of ways that physical therapy can help after surgery, specifically in HIPEC, and Tal mentioned this in her presentation as well. I think the biggest thing that we find with patients post-HIPEC is the fatigue and change in activity level as they recover. On average, I think we see it takes about 2 to 3 months for patients to really feel like they can start to re-engage with meaningful exercise. And so our goal post-op is to try to give you recommendations on how to do that gradually, because we know your body's recovering from a very large and very intense surgery. The other way that PT can help is also with scar tissue healing. So Dr. Sharib had that slide, which sort of showed where the incision is on the abdomen. And at about 6 weeks post-op is when we can start to instruct you how to do scar tissue massage. It really can help break up some of that scar tissue, which we need for healing. But what can happen is if the body lays down a lot of scar tissue, it can become uncomfortable at the abdomen. So the hope is that we can sort of alleviate some of that discomfort and help you get moving and feeling better when you move. And then also just returning to daily activities. So we can make some recommendations there just on how to do that in a safe manner. And then this last part here is just some common side effects from surgery and cancer treatment. So Dr. Cohen was talking about some of the neoadjuvant chemotherapies that patients may undergo. And so these are just some common things that physical therapy can also help to address. A really common one is neuropathy from chemo. There's unfortunately not a ton of research done on the chemotherapy, neuropathy induced by chemotherapy. However, there's a couple things PT can work on, and really what we're trying to do is maintain function. So we're working on balance, maintaining dexterity in the hands and feet, since that seems to mostly be what's affected by chemotherapy-induced neuropathy. The other thing we've instructed patients in is a neuropathy massage, which won't necessarily take the neuropathy away, but it can help alleviate symptoms somewhat. And then at Fred Hutch in clinic, we also have a low-level laser, which has some very minimal data. There's a lot more data in diabetic neuropathy, but it seems to have helped anecdotally in some patients to help mitigate or decrease symptoms. Again, doesn't take it away entirely, but can help improve symptoms. The other big thing that our clinic focuses on is lymphedema. So if your surgery happens to involve lymph node removal or your treatment plan involves radiation treatment, all of our therapists are lymphedema certified. So we help monitor, educate on sort of what to look for. And then if lymphedema does occur, we're instructing on how to address that with lymphatic massage, compression, and exercise. Again, limitations in strength and endurance, especially after surgery. This is sort of kind of the bread and butter of PT. We're really trying to make sure we're getting you back to your day-to-day tasks and the things that you want and enjoy doing. And then, as mentioned before, discomfort at the surgical incision site. So we can see you in clinic and actually do the massage on you, and then also teach you how to do it yourself, or have a caretaker do it for you after surgery as well. So if you're finding you're dealing with any of these things and you haven't seen a physical therapist, we'll recommend reaching out to your oncologist or your surgical team and asking for a referral so you can be seen and assessed by a PT. And that's all I have. Thank you again for inviting us. We appreciate it. And I can answer any questions that come up.
Thank you so much, Jenica. Our next speaker is Regis. Barb is an amazing team member as part of our survivorship clinic, one of the PAs at the Fred Hutch, who can speak from personal and experience of just her own training and taking care of patients from a variety of different cancers from the standpoint of dealing with the long-term effects of cancer and some of the issues that come up.
Thank you very much. Can you see my screen?
I see it in the regular mode, not presenter mode, but we do see your slides.
Okay, thanks. Thank you so much for the opportunity of being here today. It's such a pleasure to be part of this program. And so let's begin talking about survivorship care. So I think before we get into that, it's important to discuss who is a cancer survivor And if we look at the guidelines through NCCN, a cancer survivor is considered a person from moment of diagnosis through the balance of their life. And this includes survivors living with cancer and those that are free of cancer. What's amazing is currently in the United States, we have 18.1 million cancer survivors as of 2023. And look at the number of people that are living with metastatic cancer, 623,405. It's amazing. You know, more than 500,000 people are living their day-to-day life with cancer. And here's the trajectory, 2022 to 2040, it looks like we're going to have 26.0 million cancer survivors. So what do we do with all these survivors? How do we move forward? That's part about what cancer survivorship is all about. So I wanted to share with you, before we dig into some specifics, a survey through NCCN that was really amazing finding for all of us that are in this space. And it was 1810 survivors and 535 caregivers. And so who considers themselves a cancer survivor? 72% of those stage 4 consider themselves to be survivors. That's amazing. And we know that everybody will determine when they feel like they're a survivor. And it's okay not to feel like a survivor right when you're diagnosed, but like maybe when you're halfway through treatment, you're like, hey, I'm going to make it. That's when you feel like you may be a survivor. The other thing is that part of cancer survivorship is a care plan. And what the care plan does, it's something that you have that you can share with your primary care providers so that we make sure that other preventative guidelines are not being missed and that you're getting the care that you need as you go through your treatments. 80% of the patients said, yes, this was a value. Caregivers, 87%. But here's what was really crazy for us is to know that 30% of the patients felt like only, 44% were getting follow-up care with their oncology team, and 30% really didn't feel like everything was being addressed. So, it brings to point here is that, as you're going through your survivorship journey in treatment and transitioning to surveillance, there's a lot of things that are happening that sometimes is not observable by your teams. And so if we look at that, we're looking at quality of life challenges. And along with that is like all the psychological stressors that are involved. So, you get diagnosis, we have great treatment plans, we go through our therapies. But during this time, there's so many things going on from a mental standpoint and physical standpoint, changes in body image, social interactions, fear of recurrence. All of these things are going on in a survivor's mindset. It's not just about surviving the treatment. It's like, what is this all about? So I love this slide because it's really about perspective. And the reason I showed this slide is because I think we have different perspectives going on. Sometimes I think caregivers and survivors are coming from a different perspective than maybe the oncology team, than maybe the primary care provider, and also, just the people that are supporting them, in, whether it be at home or, from afar. Everybody has a different perspective about what that cancer journey really looks like. And the reason I say that is because I'm somebody, and as was alluded in the introduction, I'm somebody who lives with a cancer diagnosis as well. And I'm still in surveillance. So I get what it's like to be the patient, but I also get what it's like to be a provider who diagnoses patients. And also in my 27 years of primary care experience. And so, I really have appreciation for also caregiving for those that have cancer. And the reason I talk about all that is what I really want to get into today is how do we go from the idea of surviving cancer to actually thriving through our cancer journeys? So, we're plowing along, we're getting treated, we're going to surveillance, but a lot of times when patients come in and see me for appointments, they're like, I'm not there yet. Or I'll have patients come in to see me and say, I don't even want to be thought of as a cancer survivor. I want to be known as a thriver. So how can we get from this point to this point to this point? And that journey looks different for everybody. So Operation Thrive, what can we control? Well, we can control our lifestyle. We can control what we do socially, our interactions, how we actually, have boundaries. That's one of the things we discuss a lot in our appointments is like setting boundaries and looking at, what's important to us in the future. And also, how can we improve our general health? Now, this is where I want to pause for a second and say, as we discuss these following things, I really want to first thank the caregivers that are out there today, because if it wasn't for you, it would be so difficult for us to continue to maintain and work through our journeys. And I want to thank you personally. And so when we talk about, the social aspects, we talk about these aspects, these actually apply to you too. So what can we do? Prevention. And this is where, as we've learned today with the great, nutrition, and exercise, alcohol, substance abuse, quitting smoking, sleep. These are all the things that we can work on controlling. Now, are these things that we struggle with? Absolutely. Probably one of the most common things that I hear in my appointments is fatigue, as was discussed earlier, but also what I hear in my appointments too is just people struggling with not being able to sleep. And a lot of times what happens is this is something that was going on before the cancer journey, and then the cancer journey just made it exponential. So working on trying to figure out how we can help people sleep is really critical in all of this from a physical and emotional standpoint. Also, not isolating. I think it's really important for us to address the emotional needs. So what happens with a lot of my patients that I see, some of them have been in counseling and some of them haven't. But what's been really interesting is that their cancer journeys have actually brought out to them previous things that happened as they were growing up or previous traumas. And so all of a sudden, they realize that not only am I needing help dealing with the trauma of my cancer journey, and as well as, the stages of grief, but also these things I've been able to suppress in the past, all of a sudden, boom, they're up in the forefront again. How do we deal with these things? So it's really important. And we talk about that a lot in appointments and getting people in the community to help, our patients and caregivers to address these issues, and letting those that care help. Sometimes that's hard because what I've found with a lot of us is that we want people to help us, but sometimes the way they offer help is not where we are at that point. And so it's setting those boundaries and explaining mindfully like what you need, what you don't need in a way that, everybody feels good about the conversation. And so that's something we work on as well. Prioritizing self-care. You'd be amazed what happens in our appointments where people are not caring for themselves. They're thinking about everybody else. I'm like, wait a second, what about you? What are you doing for yourself? These are things you can control, making yourself the priority. Managing stress, as we talked about. And also just, relying on your pets. Pets can be great. How do you learn unconditional love? Unconditional love is from that pet that no matter what's going on, comes up to you every day and gives you that big look on their face and wants to just spend time with you. And then also the general health. And this is where in our appointments in survivorship, we really key in on like what can we do to support the PCP to make sure that, hey, they realize that they're responsible for certain things and that things are not being lost. So even though you're going through your cancer journey, it's important to check in with primary care on an annual basis and get a general physical if you're at that point that you're stable enough to be able to do so, and also emotionally stable enough to do so. So it's something to think about as you're going through checking back in with primary care. Also addressing other chronic conditions, because we know if these things are not being addressed, then we may not rehab well, concerning, our treatments and things like that. Are females getting mammograms? Are people getting DEXA scans? Cancer screenings, these things still need to be done as we're going through our journeys. And these are things that we really key in to make sure that the patient is aware of and the primary care provider is aware of. So as I said, in survivorship, there's so many things going on. It's this big, piece of pie here, and there's like so many different issues that can hit everybody. And I think what I try to do is like hit, for patients that are going through HIPEC, cognitive issues may be an issue. We know pain's an issue, insomnia, the anxiety, the fear of recurrence, how am I going to move forward as far as like my family relationships, financial. And then also, again, like I said, the care plan. So what we do in survivorship visits is see where a patient's at and try to figure out how we can help you moving forward. So like, for example, let's say you are having some neuropathy. Well, we can figure out who is a good resource for you, whether it be in the Hutch or an outside resource, and get you referred to those people. The whole idea is empowering you moving forward. And so, everybody here is welcome to come to a survivorship visit. It's a 60-minute appointment. And again, what we do is very customized to your needs, and it's covered by insurance. It can be telemed. It can also be, an appointment in person. As long as you've been treated, in, the Hutch, you're welcome. But those treated outside the Hutch are welcome, as long as they're in the state of Washington. And so we hope that our goal is that anyone that feels like we can be of benefit to them, they are welcome. And so I want to end with a final prescription here, and this is my gratitude prescription. Take a dose every morning. It may cause a shift in perspective, may cause feeling of abundance, and hopefully I hope that this prescription will help decrease feeling of anxiety and fear. And on that note, if there's any questions, I'd be happy to entertain those in the chat.
Thank you so much, Barb. Cannot emphasize how important this aspect of care is for a lot of our patients. We frequently tell our patients once they're in their surveillance phases that even though cancer is always going to be at the back of their mind, getting on with their lives is very, very important, because it's really important to try to feel like you are normal and that the cancer is not taking complete hold of your lives. So thank you again for that very enlightening talk. All right, with that, we'll move on to our next speaker. I am very pleased to introduce James Carroll. James is a founding member as well as the president of the Appendix Cancer or ACPMP Research Board. He, along with multiple members of his team, have been very active raising funds for appendix cancer research, as well as organizing regular fundraising events and encouraging researchers all across the country providing funding for researchers all over the country to perform important work in this space. So without much ado, Jim.
Thank you, Doctor. It's a privilege to join you folks today and share a little bit of the ACPMP story and give you a little bit of an overview and an update. I want to commend the Fred Hutch team for their outstanding event this year, as always. In 2006, I lost my best friend, Dutch, Judy Culbertson's husband, to appendix cancer. And shortly after that, Judy and I started to try and make a difference and set up a walk and raise some funds, only to find out that we really didn't have a good place to put the money with anybody focusing on appendix cancer back then. Thankfully, that changed in 2008 when Lisa Kurtz-Luciano and a small group of caregivers and appendix cancer patients formed the nonprofit ACPMP, and Judy and I joined shortly afterwards. Our mission has remained very much the same since inception, and that is to fund and support research to discover new treatments for appendix cancer with the hope of one day finding a cure. Also to fund and support educational programs for healthcare professionals, patients, caregivers, and families to keep pace with the evolving science and to increase awareness about this rare cancer. All of this work is done by the generosity of our donors. So we're grateful, and no donation is too small, too large. We welcome all donations. This is our team. We're a small team, an impactful team. The board is made up of all volunteers, and all of us have been affected by appendix cancer. Kim and Dustin just recently joined us on our board this year after having an impactful role as volunteers. Alyssa and Margaret are our staff. and they do a wonderful job supporting all aspects of the foundation and the patient and caregiver community. Our mission is from the heart. We are very fortunate that we have a longstanding medical advisory board of subject matter experts that are led by Dr. Laura Lambert. We're appreciative of their ongoing support and guidance. Recently, Dr. Misraji retired, and we'd like to thank him for his service. And we welcome Dr. Pai to our board, and we look forward to working with him. We also have the benefit of a scientific advisory board that is led by Dr. Halavate, and they've been instrumental in building and facilitating our grant process, and we're appreciative of their support and guidance as well. These are the core areas of focus. Research, we've funded over 2.1 million in grants as of the end of last year, including on an ongoing basis our Catalyst grants and our support of SSO. Education and awareness like today's event, a variety of resources and support that are listed on our website, tools like our new patient guide, educational videos. Fundraising is the lifeblood of all of that supports all of our programs. So this gives you a good idea of what the scope of what we try to do is. These are the areas where we try to focus on patient support, and you can see we've got new patient guides, clinical trial repository, a patient registry. In that area, there's a platform that ACPMP collaborated with NORD that is about to launch in the spring. We have a Find a Specialist tool that we just updated last week with current information, and we've extended it beyond the US at this stage, and published research repository. These are areas that Deb Shelton focuses on and is fantastic at driving. The Catalyst grant have been really the core of our grant program, and they are $50,000 grants that are paid out over 2 years. They support basic scientific and clinical or translational research for appendix cancer and PMP. As far as our grant program in 2024, we're very proud that we were able to give two $50,000 grants that went to Dr. Paul Shen of University of Texas, Dr. Patrick Wagner of Allegheny Health Network. We also funded a Young Investigator Award through the Society of Surgical Oncology for $25,000, and that went to Dr. Michael White. And we funded 18 $1,000 grants that enabled researchers to attend the SSO conference and present their research. At the end of 2024, for the first time ever, we were fortunate that we were able to do one more grant cycle, and we provided a grant to Dr. Andrew Lowy. We also, from a commitment standpoint, are increasing our commitment with SSO. In February of this month, we will be announcing next week a clinical investigator award for $100,000 that is named after our founder, Lisa Kurtz-Luciano. Once again, we'll have a Young Investigator Award that we're announced, and we're funding 10 $1,000 grants for additional researchers. Our 2025 strategy remains the same, that we'll start with our $50,000 grants, and potentially we evaluate it every year and see if there's an opportunity to expand that. So $2.1 million since the beginning in 2008. We're very proud of that and the impact that it's having on patients and the physician community. As I said, all of this is based on the fundraising and peer-to-peer events that are done. You can see the wide range of types of events. This month in March, we're excited about Mary Claire and Rob O'Neill are hosting a very outstanding cornhole tournament in Massachusetts. And we are inspired by them, and we're currently planning multiple cornhole tournaments nationwide with a newly formed relationship we have with the newly formed Beach Football League. The first one's in Jacksonville in April, so we should start publishing that on social media. Volunteers have been critical to our foundation's success from the very beginning. We're appreciative of their hard work and ongoing support. You can see the many volunteers that day to day help us in a lot of different ways. We always welcome anyone else that wants to step up and volunteer, whether you can give a lot of time or a little time. We appreciate anything that can be done. So I want to thank everyone for joining us today to learn about ACPMP. Thanks to the Frank Hutch team and PMP Pals and all the presenters. Great job. And to the patients and caregivers, thank you for your attendance today. All our efforts are to support you and to provide hope. Please know that you're not alone. Stay strong and never give up. Thank you all. Appreciate it.
Okay, thanks, Jim. Then the next presenter is Adele Jason. I have known Adele personally for more than 8 years. She belongs to the PMP Pals organization, which is a nonprofit group that is comprised of PMP survivors as well as caregivers that are committed to offering support, also access to information and hope to a lot of PMP related and related cancers. She's the president of this organization, and we're very excited and honored to have her speak here today.
Thank you, Dr. Mogal. Can everyone see my slides?
Yes.
Okay, perfect. Yes, so our organization was founded back in 1998 by our founder, Gabriella Graham. And Gabriella was really a pioneer in recognizing a critical need for this rare disease in terms of providing accurate and correct information and starting this global community which has grown to what we are today. Gabriella, like I said, sadly passed away in 2014. And we continue on, but we are the world's oldest global volunteer-run organization supporting those diagnosed with appendix cancer or PMP and caregivers. We are run by our board of directors, and hopefully you recognize many of the faces on here. Myself, Charmaine, Mark, Dave, and Mike Weber. And our commitment is to carry on the initiative that Gabriella started. We couldn't do it without all of our many volunteers. Our volunteers are the heart of PMP Pals. We show up every day, day in and day out, to provide real-time support to patients and caregivers. And I'm just going to call out a few names of our key volunteers, but Jamie, Connie, Lindsay, Roberta, Misty, Linda, Taryn, John, Sherry, and Harold. If you're out there, heartfelt thanks for all that you do. PMP Pals is about community, and we provide various forms of contact for patients and caregivers to connect with us. One of our most popular programs is our Hope Zoom program. We regularly hold group Zoom calls Saturdays at, I'm on the Eastern time zone, so 11 a.m. Eastern, and Wednesdays at 6 p.m. Eastern. We did have a call this morning, and we learn so much from each other. We're there for the newly diagnosed, for the long-term survivors. We are a safe place for patients to connect during good days and bad days. You know, we're there with you to celebrate your good days. We're there with you to get through the bad days. And we just learn so much from the experiences we have from each other. One-on-one mentoring, and we form these relationships, and we often connect with others online to to provide that sort of support. We have an annual patient meetup, and as much as we love seeing everyone in the little squares on Zoom, that there's just nothing like connecting in person. And we do other activities. You know, our pals get together in regional areas, and one new initiative that a patient did last year to support a milestone birthday is we had our 1 in a million 5K race down in Austin, and that helped raise awareness. We regularly send out a newsletter with information, and we also have an active Facebook group. And we do subdivide, to certainly have certain caregiver sessions, because as Barb so correctly mentioned, the caregivers are a key part of the group needing support. We often say, the physical journey is tough for us patients, but so is the emotional journey. And, we're there to help support that emotional resilience. Again, we're all about support. We have a lot of, current and relevant information on our website. We are bound and determined to make sure every person in our community knows that they're not alone. And we have, tailored programs. As I mentioned, we have the Hope Zoom calls, but we also send tangible things to our patients, such as our Broad Blankets program and our Bare Bottom Bears program. And I'll talk a little bit about both of those in a minute. But as I said, we're always open. So whether you're connecting with us through our Hope Zoom calls, social media, emails, texts, calls, we are here. So many of us benefited from the interaction we had with others, and we're just, vigilant about making sure others receive the same support that we received. The Broad Blankets, and Lindsay, if you're out there, heartfelt thanks. Lindsay's our patient where her dad is able to help us send blankets to our patients, typically before they go in for surgery, because that's something that all of us need, helps us feel comforted. Bare Bottom Bears. In Gabriella's day, these were sent out, and we continue to do this. It's just a tangible sign of hope and encouragement to our patients, a reminder that we're here and you're not alone. Another program that goes back to Gabriella's day were our Thinking of You and More cards. We send cards to patients preparing for surgery, going through a tough time, any reason really to let them know we're thinking of them. And there's just nothing more heartwarming than to receive a package of cards in the mail from other patients and caregivers, reminding you that you're not alone. And we do have radar. These cards do seem to show up just at the right time, for our patients. And so we're really, really proud of that program and all of the card writers that take time out of their day to write these cards to our patients. Just our community impact, just to give you some idea of what our reach has been in 2024, we had 72 Hope Zoom meetings, 9 specialist presentations, over 1,700 Hope Zoom attendees, more than 1,200 cards sent, over 40 bears sent, over 45 blankets sent, and over 5,000, probably more, personalized mentor connections. And each of these represents a moment of hope, support, and connection reinforcing our mission to stand alongside those affected by appendix cancer and PMP. We're also proud of the collaborations and partnerships that we have. One of those is the privilege of being able to present at this Fred Hutch session. Our patient and caregiver community has provided input into various surveys and research going on. We appreciate the collaborations we have with ACPMP and we've done some collaboration with Cancer Patients Europe, and our reach is wide. And I've said on these presentations before, any illness is awful, but when it's a rare disease, knowing that you're not alone and knowing that there's reason to have hope is so much more important. So you can get involved by bringing hope to PALS. Attend one of our Hope Zoom meetings, open patients, caregivers, medical professionals. Spread the word about PMP PALS. We'd love to have you join and see what kind of support we can provide to you, or learn how much the kind of support you can give to others. Engage with us on social media, host a 5K, as I mentioned, the one patient did, or Facebook fundraiser, provide, donation or sponsorship, or just volunteer. A card writer is an example of something that, most everyone can do, and every action, big or small, counts. So you can find us on our website, pmppals.net. Feel free to send us an email to info@pmppals.net, and we're on Facebook, LinkedIn, and Instagram. But again, we appreciate the opportunity to be here, and we hope you will connect with us.
Thank you, Adele. And with that, I'll hand this over to Dr. Cohen for conclusion. She's going to go over some of the latest trials at Fred Hutch before we end the day.
Great. Okay, sorry, just trying to share my screen here again. Okay. Great. So I just wanted to end, as we are thinking, very forward thinking about the future. One of the things that we'll talk about are clinical trials. And so I'm just going to talk a little bit broadly about that, because I think that's a question that comes up a lot. Sorry, my slides are not advancing. Okay, so first of all, we are speaking on behalf of Fred Hutch, but, not everybody is located here. Last year, we even had international attendees. So I understand it can be extremely difficult sometimes to apply the information that we're describing to you in your local center. But one place to go is this clearinghouse of every single clinical trial in the United States will be in clinicaltrials.gov. You can search by your condition, or if you have a specific mutation or something that will help you find a trial. And so just for awareness, as you look at different trials, we have generally phase 1, 2, and 3 studies. The purpose of a phase 1 trial is to try to test the safety of the drug or combination and the best dose, and everybody gets the study drug. Sometimes these are going to be first in human studies. They've never tried it in people before. And sometimes it's going to be just a drug that maybe it's been tried, but it's in a new indication or new combination. And often the slots are extremely competitive because they only enroll a few at a time. If you have phase 2, we now have figured out the dose, and we're trying to figure out an early signal of efficacy. Again, everybody gets a study drug, but really, for the most part, rarely they can be randomized phase 2, but generally everybody gets a study drug. And then phase 3 is that proof of concept, or trying to see if this treatment is better than standard treatment. So these are usually the typical ones that you think of as being randomized, sometimes a placebo, sometimes they just, the computer will randomize you and you'll know which one you're in. So it kind of depends on how it's done. And I bring that up because as we think about trials, different people are more or less excited about participating in research, and might affect whether or not you want to study or want to travel for a study. So at this point, we do not have any all-comer colorectal cancer studies or appendix cancer studies. We do have pipeline trials for KRAS and PANRAS inhibitors. I say pipeline to mean that they're in the startup process and they're going to open sometime in 2025. They don't have a specific date. We have a study with a KRAS G12C inhibitor, a MET inhibitor, and a bispecific EGFR inhibitor. So really knowing the molecular profile has been extremely helpful. Unfortunately, many of these studies do not permit appendix cancer. Appendix cancer being rare often is excluded from studies. And so we have to look sometimes at trials that are off of a specific mutation or an earlier phase. But I do really encourage you to talk to your medical providers if you're interested in a clinical trial to see if there's something available. No for a phase 1 trial. Those might be the really exciting ones. There's a new drug. We are really excited about it, but they often open and close. And when there's a slot, they can have to be taken pretty quickly. So if you're interested in a study, you may need to check back often, be engaged, see if you can be on a waiting list. As has already been hinted by Dr. Sharib, we hope to eventually bring PIPAC to Fred Hutch. So there is some interest in this that's been explored at City of Hope. But while we have sent patients down there, I do want to note that you cannot have cancer in other sites like the liver. So it's really for peritoneal only disease. Dr. Sharib has a CUNY grant foundation. I also have 2 different biorepository grants where we're trying to really understand more about what makes appendix cancer tick, what makes colorectal cancer tick when it spreads to the peritoneum. So doing tissue and blood biobanking, doing sequencing. We have opportunities to explore how cancers respond out of the body. That's called slice culture, looking at the immune environment, and really even start to test new treatments. So just want you to know that we are, participating in these types of trials and have research ongoing. So if it's something of interest, we're happy to talk more about that. And as I said, we do have a biorepository collecting peritoneal washings, and one of my big areas of research is in ctDNA, so looking at investigational use using commercial assays and also assays that are not yet available on the market. And that's all I have to share to kind of conclude this. I want to thank you so much for joining us today. We really feel that information can help inform people better understand different parts of this journey, and hopefully we'll have answered some of the questions or maybe brought up new ones that you want to speak to your medical providers about. But we will stay on for the last couple of minutes and just answer any questions that come up on the chat. But thank you to everyone who joined us today.
Thank you, everyone. Please, please, please fill out the survey. That really helps us identify areas you'd like us to, focus more on for subsequent years. And if you have questions about consultation with us, please don't hesitate to reach out to the organizers. They will be more than happy to direct your emails or questions or concerns directly to us.